Uh, Good morning. Thank you for inviting me and kind introduction. I'm very honored to be here and to be given a chance to share my ideas on how to combine the various therapies that are necessary to achieve optimal aesthetic and functional result. Team Atlanta and my group, 5D Japan, have been collaborating for over 10 years now. And we have been fortunate enough to have spent a lot of time learning together, not only in the clinical environment, but outside too. Before starting my topic, I'd like to show a case that's very interesting for me. As you can see, there are many deep infra-bony pockets. The defect at number 44 almost reached to the apex, and the furcation involvement at number 46 was class 3. The volume rendering images also showed bone defects which included furcation involvement, supracrestal and infra-bony defects. After flap elevation, we could see the challenging reality that we are working with. Looking in detail at the tooth number 44, after debridement, it was positioned linearly from the adjacent teeth. But the bone graft, after the bone graft, the number 44 was infra-buccal position. Clearly, we were working with teeth with a little more than usual mobility, like this. The bone graft was then covered with collagen membrane, and primary closure was achieved with layer combination of mattress and simple sutures. Here are the 5 years results in the molar region. The infra-bony defect was almost completely filled. These before and after CBCT images shows significant improvement of a severe furcation defect from a class 3 to class 1. Here is the premolar region. The teeth that show severe mobility were firmly supported by the regenerated bone and functioning independently. Comparing CBCT images shows significant improvement at tooth number 44. The patient had a large amount of bone fill and great attachment gain with minimal recession, especially in the interproximal areas. He seems to be very happy with the outcome. Even if the attachment loss reached to the apex and the mobility is very severe, we still have a chance to save the tooth. As a dental professionals, we should strive to preserve natural dentition whenever possible. Okay, let's start my topic today. Today, I'd like to talk about how we manage these type of complex conditions which significantly affect patients both physically and socially. The real trick is knowing when and how to use orthodontics, bone augmentation, and soft tissue management. I'm hoping that I can provide some guidance on this matter today. Although these complex cases can be slightly overwhelming at first, if we simplify the procedures and tackle each issue in turn, then they can be manageable. The foundation of our combination therapy involves these 6 simple components. Working systematically through their requirement, we believe that we can achieve successful results in every case. I will spend most of my time today focusing on site development and space management. Orthodontics and implant therapy have a positive interactive relationship. To gain this positive influence from orthodontic and implant therapy, we have to manage the timing and sequence of therapies. I believe that there are 3 patterns in implant ortho case. The first, OI, is also followed by implants, and then final restoration. Orthodontic treatment is made possible by using the natural teeth as reciprocal anchors. This patient presented at my office requesting an implant in the right central incisor position. I'm guessing that no one would try to replace her number 8 incisor without space management. Orthodontic treatment using reciprocal anchors was performed prior to implant placement. The aim of orthodontic for adults is to achieve +1 canine relationship, stable molar occlusion, anterior coupling, correct occlusal plane, and an aesthetic result. This is the same patient 2 years later. In OI cases, the key for success is simply good orthodontics. Thinking of the recent work on lifelong craniofacial growth, when we treat this kind of patient, we must always consider the possibility of autotransplantation of excess teeth. Sometimes we cannot place implants without orthodontic therapy. The second pattern, IO, is used when there is no vertical occlusal support and no available anchors for orthodontics. Implants must be placed first to provide anchors for the orthodontic treatment that follows. The final pattern is a combination of the previous two, and the order of treatment can vary from case to case. This combination pattern is used when the implant position is initially difficult to anticipate. Even if the reciprocal anchors are inadequate, the initial orthodontics can be used to make final implant planning, placement, and subsequent ortho easier. Occasionally, temporary anchorage devices can be used. This patient was referred to my office for treatment of this congenital condition. She was missing 13 teeth, including all her premolars, bilateral upper canines, and 3 lateral incisors. Both upper and lower arch size and shape were in good condition, but she had a space problem complicated by microdonts. The remaining primary tooth roots were ankylosed and had created an infraocclusion. A left side view showing a similar condition, the existing molar relationship needed to be adjusted. She had a high smile and had been having functional difficulties for a long time. After removing the primary teeth, it was clear that we needed implant to act as anchor for the orthodontic therapy. But how do we decide on implant positions? The only way to anticipate the correct implant position is to prepare orthodontic setup models. Occasionally, there may be differences between our goals and the goals of our orthodontist. It seems that orthodontists usually don't like to move molars. My orthodontist and I believe that as we gain experience, we have realized the anchoring potential of dental implant, and that there are big differences between implant anchors and temporary anchoring devices. So much so that we are reconsidering the way we plan tooth movement. Here are the steps for anticipating implant positions. Step 1, create landmarks on the working model. Step 2, prepare an orthodontic setup model and works up by using a duplicated working model. Step 3, using a silicone index, records the positions of the works-up in relation to the landmark. Step 4, using that same silicone index, transfer the works-up positions into the original working model. Step 5, the works-ups can be transferred to the diagnostic template on the original working model. The diagnostic template is placed in the patient's mouth, so we can determine the relationship of future crowns and the bone foundation. In the maxilla, we had 4 consecutive bilateral missing teeth. Where do you think we should place implants? Considering the available space and using simple calculations, we can see that the implants must be placed in very precise positions. Tissue requires a minimum distance from 1.5 millimeter from natural teeth and 3 millimeter from other implants. So, when we place a 4 millimeter implant, we need at least a 7 millimeter space. Natural premolars are also approximately 7 millimeter wide. Therefore, placing 2 implants into the premolar region really leaves no room for error. When we place implants before starting orthodontic treatment, we must consider the influence of orthodontic movement. And remember that the teeth do not always move as planned. So there are 4 clinical recommendations for successful treatment. Do not place implants into the small tooth side. In more aesthetically demanding side, use Pontic if you can. If possible, use Pontics beside the remaining teeth to allow for any unaccepted future movement. Select smaller diameter implants and use platform switching. Even with careful planning, our entire case can fall apart if implants are not placed into the planned positions. Bone augmentation with GBR allows us to place implants where they should be. During orthodontic treatment, tooth movement is re-evaluated periodically. Occasionally, the original orthodontic treatment plan is adjusted. In this case, the planned 3 lower incisors were adjusted midway through the treatment in order to place an additional incisor. In this type of situation, the Pontics that were placed beside the remaining teeth become essential for accommodating the evolving oral environment. In the mandible, the number 28 implant was placed into the space created by using the previously placed number 29 implant as an anchor. Once again, taking into consideration the 7 millimeter tooth width and the 4 millimeter implant diameter, you can see that there is very little room for adjustment. As can be seen in this result 2 years after treatment, if we take our time and use careful space planning, a successful result is possible. In this right side view, the molar relationship is clearly not ideal, but canine positions are adequate to protect the molar. A similar situation was found on the left side. Implants are precisely placed into their planned locations. 10 implants with 2 Pontics and cantilever adhesion bridges were used to replace 13 missing teeth. Good anterior coupling was established through implant treatment, orthodontics, ceramic restoration, and direct bonding. With good anterior coupling, we also achieved good anterior guidance. Lateral movement was controlled by implant-supported maxillary canines and direct bonding on the reshaped mandibular canines. This patient came to my office as a 19-year-old student with an oral condition that was really influencing her life. 6 years later, she is happily married with a young child and a beautiful smile to show it. Hopefully, she will continue to enjoy her new teeth for many years to come. Now, I will shift our focus to tissue management using orthodontics, GBR, and connective tissue grafts. This 55-year-old woman presented with tooth mobility. She had significant horizontal bone defect on all remaining teeth. Considering all of the variables in this case, we decided to treat entire maxillary arch with implants. From the resting upper lip position and the tooth display, we can see that although the incisors are too buccal, the vertical position is acceptable for aesthetics. But the alveolar bone level was greatly receded. If we extract these anterior teeth, the soft tissue level will recede more, and the crown length of the final restoration will be too long for an aesthetic result, even if socket preservation is performed. It is ideal if we can vertically regenerate the alveolar bone approximately 3 to 5 millimeters without soft tissue collapse. Implants were placed in the molar region with sinus lift and ridge augmentation. These implant positions were determined with an orthodontic setup model, as I explained previously. After establishing occlusal support and implant anchors, orthodontic treatment began. Using the technique Henry and Morris mentioned in this article, loose extrusion was performed to vertically regenerate the anterior alveolar bone. Dr. Francesco Amato extruded 32 periodontally damaged teeth and replaced the roots with 27 implants in 13 patients. He found that an average of 70% of the extruded length was accompanied by regenerated bone, and 6% of the extruded length was covered with soft tissue. Even limited tooth attachment still has the potential to regenerate both soft and hard tissue through extrusion. The extrusion rules that were complied in this review by Koraima et al. A very good start for implementing this technique in your daily practice. Use light force with a slow and steady rate, and plan for stabilization period that directly corresponds to the time of active extrusion. This is a buccal root torque case that our colleague, Dr. Tanno, performed. Sometimes simple extrusion can increase crest height, but still not thick enough for implant placement. By torquing the root buccally, the crest gained hard tissue volume behind the root as it pivoted out and up. This idea was introduced by Dr. Nozawa's team in 2003, and we learned about its clinical potential from Dr. Amato's cases. After 2 months retention and extraction of the root, the ridge was completely regenerated, and the implant could be placed without flap elevation. In the final restoration, we can see a natural emergence profile supported by stable regenerated bone around the implant platform. Going back to my case, comparing these X-rays and lateral views of before and after extrusion, we can see the anterior alveolar crest was vertically augmented. As we talk about extrusion today, it may seem like it is an easy procedure to perform. But for the most orthodontists in Japan, this is a very new concept and requires much more work than we might imagine. Brackets are reset multiple times. Torque and angulation must be considered as the bracket is placed on the roots as well as the crowns. And as we know, orthodontic work is reciprocal. As one tooth is extruded, the neighboring teeth are intruded. We simply think we will extrude a tooth, but our orthodontist must create and follow a very detailed plan to make that happen. From the stress of this procedure, my orthodontist has lost over 20 kilos. Not really, but it could happen. Of course, sometimes this can be a good thing. To be honest, this is a result over 1 year of hard training, and maybe a little stress from my orthodontic demands. After an appropriate retention period, actually 6 months in this case, immediate implant placement follows extraction of the previously extruded numbers 14, 12, 22, and 24. Implants are placed into the ideal positions, which was most palatal portion of the sockets. Dr. Manku also reported successful cases using this technique in these 2 papers and on the Dentally SP website. After finishing extrusion, the remaining teeth were maintaining the soft tissue frame, but attachment apparatus wasn't sufficient to support crowns or fixed bridges. If these teeth were extracted, this improved hard and soft tissue architecture would change, even if a socket preservation procedure was performed. This scenario is a very good indication for root submergence technique. To avoid relapse, we recommended to retain the extruded teeth for as long as possible. We were originally introduced to this idea of RST and extrusion by Team Atlanta, and were fortunate enough to co-author this article about the advantages of the root submergence technique. In this case, I completed a number of years ago. The left central incisor was cut at the crestal level and submerged under the soft tissue. You can see that the papillae around the submerged root are quite similar to the papillae adjacent to the natural teeth, even after 8 years. And the interproximal bone peak around the submerged root maintains ideal aesthetic height. Extrusion and RST techniques can be very beneficial in creating an aesthetic soft tissue frame, but they are not without risks. After treatment was completed, this patient was not satisfied with the overall result. In particular, she was concerned about the black triangle between her central incisors. RST was performed at the tooth number 8 site in this patient, and in the X-ray, the submerged root seems to have been covered successfully, but the final result left a very visible black triangle in the aesthetic zone. Thinking back to when I had just completed the extrusion, I must admit that I was very pleased and expected an amazing result. Even during the RST and initial healing phase, I was quite optimistic. But this is the reality of what was happening inside. This root was extruded to vertically augment the alveolar bone. Then, after extrusion, it was retained for 3 months. Unfortunately, 3 months retention appears to have been insufficient. If I could have preserved the bone peaks immediately after RST, which is shown by the yellow arrow, the papilla would have remained at the level of the pink arrow, but I couldn't. So, over 6 months following RST, the bone relapsed and the corresponding papilla disappeared, along with my expectation for an impressive result. We offered retreatment, including an additional extrusion procedure. But she selected the speed and the ease of a gingival-colored prosthesis. You might be thinking that even if I extrude the tooth again, we would experience the same unfortunate result. This next case demonstrates one possible solution. These 4 incisors were over-extruded and retained. The retention period was slightly longer at 4 months. We can see the unsolved periapical region. Instead of treating the lesions with endodontic surgery, we chose to cut all ligament and remove the teeth for treatment. Looking at these very thin interproximal bone peaks, we realized that a simple socket preservation procedure would not have been able to preserve the peaks. The root canal was filled in a retrograde fashion, then delicately replaced into their sockets. I tried to preserve supracrustal fibers as much as possible by only grinding down the root to a level slightly above the socket bone. Connective tissue was grafted over the root to cover the area. Comparing X-rays before RST and after treatment, there was no evidence of relapse, and we gained ideal papilla peaks. I have not done the research yet, but from the result of this case, I can hypothesize that cutting attachment ligaments to temporarily remove and replant roots, followed by RST, can limit or avoid the relapse of submerged roots. These are before and after treatment. Recalling my experience with my last patient, it is clear that although the papilla is physically a small amount of tissue, it can significantly change the aesthetic outcome of a case. Using this exclusion, intentional replantation, and RST treatment plan, I believe that it is possible to avoid relapse after vertically regenerating hard and soft tissue. To return to this patient I previously spoke about, comparing the apex and bone level of these bilateral central incisors, we can see that all anterior teeth were extruded to the aesthetically ideal positions. The amount of extrusion was determined related to the attachment level for each tooth. In the final restoration, submerged roots are maintaining the improved interproximal height of bone as ideal vertical position. We can see how the periodontal attachment apparatus has astonishing abilities to augment and preserve alveolar bone and soft tissue. We started with a very compromised environment, which included tooth drift, deep pockets, and considerable vertical bone loss. And due to an open-minded interdisciplinary approach that allows practitioners to pick and choose the best from many fields, we were able to achieve these favorable functional and aesthetic results. We think that strategically needless teeth are not hopeless teeth. They do not necessarily need to be extracted. Using the root submergence technique, sound vital teeth or extruded roots at the pontic site can evolve into variable roots. We often encounter many patients such as these, who have already lost alveolar bone. Obviously, their quality of life is significantly affected by this condition. In multiple implant cases, we must mimic a natural healthy appearance by managing surrounding tissue with abutments and superstructures. To achieve this kind of result, we first need to recreate a sufficient bone foundation. What is the goal of bone augmentation in the aesthetic zone? This patient had lost his teeth in a car accident almost 10 years ago when he was in his early teens. As he got older, the injured and connected teeth couldn't erupt correctly. This situation resulted in substantial vertical bone loss with an open bite. Due to his high smile, this vertical defect was much more difficult to reconstruct aesthetically. After extraction of the hopeless teeth, this defect appeared. The diagnostic workup showed that the mesiodistal space was limited. So the 4 teeth were planned to be replaced with 3 units. Diagnostic template and CT scan images confirm a significant vertical bone defect. For horizontal augmentation, Dr. Yuri Grunder's team found that bone thickness of at least 2 millimeters at the platform on the buccal side was necessary. This regenerated bone would counteract recession and papillae loss caused by normal bone remodeling and insufficient thickness. This idea is one of the foundations of our ridge augmentation procedures. Please note the 3 simple titanium mesh frame covering the buccal arc, and that 7 months later, the buccal thickness of regenerated tissue was more than 4 millimeters. Back in 2010, we introduced 3 intraoral vertical standards: the 4 millimeter interproximal height of bone IHB, and the line connecting adjacent bone peaks shown here in yellow indicated the necessary amount of vertical ridge augmentation was almost 9 millimeters. After implant placement, the third standard of 2 to 3 millimeters from the platform indicates the same goal as the first 2 augmentation standards. This means that there is a correct relationship between the design goal of the superstructure and the remaining periodontal tissue of adjacent teeth and implant positions. GBR3 with 3 simple titanium mesh frames and collagen membrane was performed. 7 months later, a regenerated tissue entirely covers implants. Returning to the vertical augmentation standards for aesthetics, simply covering implants with regenerated tissue is not enough. There was still a 2 to 3 millimeter space that needed augmentation to establish aesthetic papillae. With temporary healing abutments acting as vertical support for the mesh. Additional GBR was performed, and 7 months later, the vertical standards were completely satisfied. After 2 augmentations, you can see a significant change of almost 9 millimeter vertical augmentation. This is the original condition and the regenerated papillae, the vertical regenerated ridge, and the final result. You can see that by using 4-dimensional planning, which includes precise strategic staging of each step, we can achieve this kind of natural-looking aesthetic result. The positive aesthetic outcome of guided bone regeneration for contour augmentation appear to remain stable for extended periods of time, up to 18 months in this study. How can we regenerate such fine 3-dimensional bone foundation? This systematic review showed that various techniques can be used to augment bone 3-dimensionally. But we must carefully choose the safest procedure for each case, depending on our individual abilities and the appropriate indication for the site. A guided bone regeneration procedure can augment alveolar bone 3-dimensionally. Looking at this case, we can see that the 2 posterior implants were placed almost entirely in regenerated bone. 10 years after treatment, the augmented bone is 3 supporting implants. Thanks to GBR procedure, we are able to position and maintain implants for a long time in sites which were previously thought to be impossible. Several years ago, the use of TR expanded PTFE membranes were very popular for vertical GBR, but it had a risk of membrane exposure and subsequent infection. The GBR procedure is easier when it is performed inside the bone frame. But when it is external, it is much more difficult. The challenges of an external GBR procedure are how to create and maintain space, and how to manage a flap to safely cover the GBR site. Recently, Dr. Urban beautifully described flap management techniques in this article. I hope he will cover this issue in detail tomorrow. As for space making, I think there are currently 3 space management options. And in my opinion, the sausage technique established by Dr. Urban is the safest of these. Non-resolvable membrane, which we learned from Dr. Yuri Grunda many years ago, is well documented and many clinicians have already commented on it, as it is still the gold standard for vertical GBR. And finally, a titanium mesh frame with collagen membranes, which is our favorite. Several years ago, we, Doctors Funato, Kitajima, and myself, collected our data of vertical guided bone regeneration cases with titanium mesh, resolvable membranes, and RHPD-GFBB. In all cases, an augmentation procedure was performed prior to implant placement. The average vertical height of the augmented bone was 8.6 millimeters after almost 8 months healing. This patient came to my clinic to get a fixed prosthesis. In her mandible, there was very limited bone height in the posterior region. An implant could be placed at the number 30 position, but there was no enough bone to place an implant in the number 31 area. In this GBR procedure, a simple titanium mesh frame was placed over the grafted materials to create an appropriate 3-dimensional ridge form. Please note that the mesh was not secured and does not cover the entire regeneration area. And the 2 pieces of collagen membrane cover the site entirely. 10 months after surgery, the mesh was removed and there was adequate width and height in the defect area, with genetic tissue covering the entire implant. Bone regeneration was proven histologically. These X-rays are simply showing the condition of number 30, 31 area before and after GBR. This third X-ray after 4 years shows the matured tissue with both implants placed in a stable environment. The number 31 implant is almost entirely supported by regenerated bone. And here are the images of the right posterior area from before and after 4 years. The left side of the mandible was more challenging due to the extensive bone loss. One advantage of using titanium mesh as a frame is that we can prepare and adjust the frame before surgery. As I think many of you are aware, titanium mesh is not cheap. So we are always nervous when we are cutting out the final frame. Having the luxury of preparing the frame before surgery means that we can design a paper frame first before cutting the titanium. This is particularly useful when we first start to use this technique. In this case, the titanium mesh was cut and precisely adjusted like this. As you can see, the space was cut out to avoid any contact with the area of the mental foramen, and the frame does not touch the adjacent natural teeth. Care must also be taken to keep the mesh away from the myohyoid line. The lingual flap was released and the mesh was placed as was previously planned on the model. When we cannot place an implant to act as support for mesh, we have to secure the mesh with screws or place temporary supporting screws inside the mesh. Collagen membranes cover the entire site. 10 months later, the ridge was 3-dimensionally regenerated. The CT simulation showed the molar implants would be completely supported by regenerated bone. Sometimes our bone regeneration is too successful, and the bone grows over the mesh structure. If this occurs, we must grind the excess bone away to remove the mesh. Please compare the original situation on the left and the newly regenerated ridge on the right. Implants could be placed in the prosthetically ideal positions with good primary stability. Looking at these X-rays, we can confirm that molar implants were completely supported by regenerated bone, as in the other cases I have shown today. Using a free gingival graft, keratin tissue was established around the implants, creating a natural-looking outcome. Our experience has shown us that a combination of GBR, titanium mesh, and collagen membranes can consistently regenerate long-term stable bone. We believe that collagen membranes in combination with the titanium framework are better than or equal to titanium reinforced membranes. It is in the aesthetic zone that titanium mesh really shows its value, if we can use it well. Mesh must be curved to accommodate the anterior ridge, and this is a considerable challenge. There are currently 3 possible solutions that we use. The first is individual strips of titanium placed to cover the majority of the site. It is easy, but does not offer full coverage. In the second solution, flat titanium mesh can be shaped by incompletely cutting along the line angle and partially overlapping the pieces. With this technique, we can adapt the mesh to the site very well. We usually use very thin titanium mesh at the 0.1 mm thickness. It is very flexible and easy to handle. The third is a very unique style of mesh, which can be adjusted 3-dimensionally without cutting. When using entire mesh material and 3-dimensional adjustment is correct, the mesh stabilizes automatically onto the particulate bone graft. Our Tokyo company has made a really useful set of pliers. With these pliers, mesh can be bent very easily and quickly. In this case, the mesh was cut along the line angle and adjusted to the anterior curve on the study model. The adjusted mesh provided a 3-dimensional frame supporting the vertically and horizontally regenerated bone to create a curved ridge ready for implant placement. Using a surgical template for evaluation, we can see that augmented tissue in this case clearly satisfied horizontal standard of GBR. We also determined that we had successfully regenerated enough of the mid-papilla supporting tissue. We see that the mid-crestal area was augmented both vertically and horizontally. Strategic pontic use helps to maintain the regenerated bone. This patient had originally severe periodontal disease complicated with tooth loss and pathologic tooth migration. Before starting orthodontic treatment, inflammation must be controlled. After orthodontic treatment was completed, number 9 and number 10 were extracted. Prior to surgery and after soft tissue healing, the bone level was re-evaluated in relation to the patient's resting lip position and smile. In the clinical environment, this bone level is determined by fabricating and using a diagnostic template. This patient presented with a very complex condition. This is after tooth removal and tissue healing. After bone augmentation and implant placement, we had a far more stable ridge to work with. Our final results show a very natural appearance in the anterior maxilla. The lateral views also shows an improved occlusal plane, canine relationship, and solid posterior occlusion. On the path between original diagnosis and final evaluation, we must first establish the optimal realistic goal, and then plan and proceed with not only intraoral success in mind, but with the overall facial appearance, including resting lip position and an attractive smile as well. So far, we have discussed space management, tissue preservation using RST, and bone augmentation with GBR. But I think there are still some issues that need to be covered to achieve a reliable, successful, and aesthetic outcome. There are several common situations related to peri-implant soft tissue. Insufficient keratinoid tissue, tissue discoloration, mucogingival junction displacement due to bone augmentation, tissue recession during maintenance period, and lack of inter-implant papilla. These cases turned out quite well, but please keep in mind that all of these problems cannot be solved by hard tissue management alone. Looking at this case, we can clearly see a significant bone loss intraorally and radiographically. Using the previously mentioned GBR technique, bone was regenerated three-dimensionally. I believe you will agree that this is sufficient. These are comparisons of intraoral situation before and after GBR. Looking at the white arrows, you can see that the base of the ridge was significantly augmented with hard tissue. But looking at the yellow circle, we still feel that the crest is not complete. If we horizontally insert a needle into this area, it can pass from the buccal to lingual side without hitting hard tissue. Deficient ridge loses not only hard tissue, but keratinoid tissue as well. The releasing incision of the periosteum of the mucosa area doesn't increase keratinoid tissue. It only stretches the flap and moves the mucogingival junction coronally. Clearly, we still have a soft tissue deficiency, despite having an inadequate bone ridge. In this case, the soft tissue was harvested from the tuberosity and grafted around the crestal area. These images clearly show that bone augmentation and soft tissue augmentation are both necessary to establish a healthy, natural-looking crest. From buccal view, we can reach the same conclusion. When we start deficient ridge, when we treat a deficient ridge, we must always consider the needs of both bone and soft tissue augmentation. Dr. Schneider and Grunder's team published a study documenting that successful aesthetic augmentation cases show us the ratio of 56% bone augmentation and 44% soft tissue augmentation. In multiple implant cases, the same principle can be applied. In this case, after bone augmentation, we still had the soft tissue deficiency around the crest, even though the amount of augmented bone was clearly sufficient. Before soft tissue augmentation, we had insufficient tissue contour. Underneath the soft tissue, you can see the three-dimensionally augmented alveolar ridge. An interpositional connective tissue graft was performed. After suturing, the crest of the ridge was shifted buccally, with tissue volume increasing in the buccal area, which was supported by the regenerated bone foundation. This is the original condition after bone augmentation and after soft tissue augmentation. To ensure successful result, when we treat this kind of severely damaged case, we should use as much time as necessary and not rush any of the stages. This case has maintained aesthetic soft tissue stability for over 6 years now. In this article, Dr. Tuer, Baumer, and Hutzler beautifully summarized the 4 different techniques for harvesting tissue grafts. I would like to show our current favorite technique to harvest connective tissue graft. Dr. Zucchelli reported the target for connective tissue graft, the lamina propria mucosa, is thicker in the molar region than the premolar region. We also agree with this idea that extraoral epithelialization is easiest and the safest technique for harvesting target tissue. Dr. Bosco reported that after removal of the target tissue, the replacement of the epithelial tissue to the donor side greatly enhances healing. Using this technique, we can control the surgical invasiveness and improve the quality of the connective tissue graft by keeping the blade above the submucosal area. Please note the consistent thickness of the graft and the depth of the cut of the donor side. In this patient, the posterior half of the epithelial tissue was replaced to the original position, and the rest of the site was protected with a piece of collagen material. This documents the healing at the donor site, comparing the 2 sides of the site. It is clear that replaced tissue has a real potential to enhance healing. How should we remove the epithelial tissue? The thickness of the free gingival graft is usually 2 millimeters or so. It might seem challenging to remove approximately 0.5 millimeter thick epithelial tissue in one piece, but there are few useful tricks. One simple tip for epithelial tissue removal is to always keep the blade parallel to the top of the free gingival graft. If the tissue is too far from the edge of the cutting base, the width of the blade holder will force the cut to be made on an angle. If we place the graft near to the edge of the cutting base, we can freely adjust the angle of the blade to remain parallel to the top of the graft. This may not seem to make much of difference, but when we cutting a 0.5 millimeter thick graft from a 2 millimeter thick uneven piece of tissue, I will take all the help that I can get. Sometimes we need more than a 1.5 millimeter thick graft. As Dr. Zucchelli has proposed, we can fold the connective tissue graft on itself to give us an approximately 3 to 4 millimeter thickness. Inter-implant papilla augmentation is another challenge of peri-implant soft tissue management. Folded tissue and connective tissue harvested from the tuberosity were both inserted into an envelope to vertically and horizontally augment the interproximal area. 2 years later, not a perfect result, but the scallop on the 2 central incisors seems more natural. Again, papilla tissue volume is small, but there was an aesthetically significant change when looking at her smile. Using this case of a patient who was injured in a traffic accident, I will summarize the steps for success with combination therapies. She lost her right lateral incisor and canine, and her bilateral central incisors were ankylosed to the alveolar bone, in addition to having been replaced in the incorrect positions. It was decided the patient needed both orthodontic treatment and orthognathic surgery. The pre-surgical orthodontic treatment used ankylosed bilateral central incisor as anchors. 6 months after extraction, we fabricated a diagnostic template which showed our goal of implant treatment, Evaluating the site, we found that there was three-dimensional hard and soft tissue loss. A computer simulation indicated that we had limited space and hard tissue to place the necessary two implants. During the healing time of the first augmentation, the angulation of the left lateral incisor was corrected. We managed to simultaneously solve both our bone and space problems for implant placement. Bone was augmented both vertically and horizontally using two main procedures, one before implant placement and one simultaneous. Connective tissue grafts were used to augment the soft tissue. After 2 months healing, we started using a remodeling technique developed by my friends at Borg in Barcelona. This non-invasive technique uses a progressively reshaped ovate pontic to gradually remodel the soft tissue. Then, after marginless abutments were connected, the subgingival contour continued to be adjusted using a provisional restoration. This comparison of tissue contour shows the aesthetic impact of bone augmentation, soft tissue augmentation, and soft tissue remodeling. Considering the base and the top of the ridge in the patient's original condition and the appearance after treatment, it is clear to see how much the regenerated bone supports the soft tissue for an aesthetic outcome. The patient was very pleased with the aesthetic transformation and can now approach the world with renewed confidence and great smile. Throughout the treatment, her natural malocclusion was adjusted by orthodontics to establish a correct anterior guidance. We use a real interdisciplinary approach to the planning and treatment to work with the complex conditions that this case presented. This approach resulted in the correction of the patient's natural malocclusion, reconstruction of the traumatized area, and the placement of two implants with a pontic. Working with orthodontist, oral surgeon, and lab technician to carefully plan the case from start to finish resulted in successful hard tissue reconstruction, supporting healthy soft tissue and stable papilla. Since 2008, when 4 colleagues and I established 5D Japan, we have been fortunate enough to study with numbers of amazing clinicians in the international community. And in turn, we are passing on that knowledge to the next generation. 4 of whom have come to support me today: Kenzo Suzuki, Masa Nakagawa, Yuki Kaya, and Noboru Katayama. These 3 are also successfully managing complex insufficient tissue volume cases. In these cases, Masa used immediate implant placement, Yuki used extrusion and RST, and Kenzo used GBR to establish a 3-dimensional bone foundation and aesthetic soft tissue contour. Looking at these natural aesthetic results, I think you will agree that if we plan our treatment properly and practice necessary skills, it is possible to achieve this kind of impressive result, even in a variety of clinical situations. Despite our patients presenting with extremely complex conditions, it is possible to restore their natural smile and give them something to really smile about. Thank you very much for your time.